Hello, my name is Jacob Lafo. I'm a clinical neuropsychologist at the Providence VA and Brown University, and I'd like to share with you today a line of research that my team is working on at the VA, looking at the interface of cognitive impairment and delirium in congestive heart failure. Um, just to start, I do not have any disclosures aside from mentioning that the data for this project derives from the VA national data set. And so the views that I express here do not necessarily reflect the position of the VA or the federal government. So I'd like to just start and talk a little bit about congestive heart failure. It's a chronic illness that results from structural and functional cardiac deficits, leading to reduced cardiac output into circulation. And there are two types, generally speaking, one involving, to the left here, a weakening of the cardiac muscle, and another on the right here involving stiffening of the cardiac muscle, both of which result in reduced cardiac output. It is a chronic illness, and one of the leading causes of hospitalization in the United States among older adults. It's the leading cause. Its prevalence increases with age, of course, as you might expect, and it's associated with significant functional decline. There's a very uncertain prognosis, and it's associated with very poor health outcomes, including increased hospital readmission, exorbitant healthcare costs, and increased mortality rate. And just to underscore sort of the public health issue associated with congestive heart failure, the 5-year mortality rate is 75%. 3/4 of patients after diagnosis have died with congestive heart failure, and that's really speaking to the severity of this public health issue. And so I'd like to talk a little bit about the heart-brain connection in congestive heart failure. Why are we talking about the heart and the brain, which are often looked at as two separate organs? And I apologize, my face is covering this illustration of the heart here. So, with this chronically reduced cardiac output in congestive heart failure comes chronic hypoperfusion of the brain, disruption of the blood-brain barrier, vascular remodeling in the brain, oxidative damage, brain-derived cytokines, strokes, and then other indirect causes like depression and anxiety and other psychological factors. CHF is associated with an increased risk of cognitive impairment, delirium, and an increased prevalence of dementia, including an increased rate of decline in patients with dementia. It's associated with reduced treatment adherence, which then leads to increased functional disability. And really for these patients, what we see is this chronic negative feedback loop where reduced treatment adherence results in increased functional disability. We're seeing greater level of cognitive impairment, which of course exacerbates this cycle of treatment adherence and functional disability. And so, we wanted to ask the question, do cognitive variables have any predictive value in congestive heart failure? Are we able to identify certain brain health variables that could tell us more about outcomes in this population? And so a key question for our research was whether cognitive impairment and delirium independently and additively increase risk for poor outcomes following hospitalization for acute CHF exacerbation. And so, our population that we studied are a highly vulnerable subset of CHF patients. They are admitted to the hospital for this acute exacerbation, which basically involves a buildup of fluid in the lungs, such that these patients cannot breathe or have a very hard time breathing. And if this issue is left unchecked, you can imagine the effects that it may have on the brain and the rest of the vascular system. We're talking about some serious cerebrovascular damage. And so these patients are hospitalized or seen in the emergency room and hospitalized. And if they're deemed to have poor independent function at the time of their discharge from the hospital, they're discharged to a skilled nursing facilities or SNFs. And as my audience here may know, that patients in SNFs are tracked with the minimum data set, which is a standardized assessment that's conducted at admission to SNFs and then at regular intervals thereafter. And some of the key variables of interest within the minimum data set that we made use of in this project were the cognitive function scale, which is a sort of very brief cognitive screening that involves both sort of an objective measure of patients' cognitive status as well as a staff report of patients' cognitive status. It's sort of akin to the MoCA or MMSE, but more of a MoCA or MMSE light, very light, and involves some immediate and delayed recall items and orientation items. And another scale that we used was the confusion assessment method, the CAM, which many in the audience, I'm sure, are aware of this. And it's an algorithm accounting for the cardinal features of delirium, including inattention, disorganized thinking, altered level of consciousness, and psychomotor retardation. And the key here is that these symptoms, these features represent an acute change in mental status from this individual's baseline. And so we're differentiating here sort of chronic delirium from more chronic cognitive impairment. And so this was our study design. So the patients are sort of tracked at their admission to the hospital. We're collecting information, demographic information on their comorbidities and other congestive heart failure variables, such as ejection fraction. And then we're tracking them after their admission to the SNF. The CFS, the cognitive function scale, and the CAM are assessed at their admission to the SNF. And then we're looking at some long-term outcomes, including mortality, hospital readmission, and functional improvement. And for the purpose of this presentation, I'm focusing on mortality for time, the purposes of time. So we had quite a large sample, over 24,000 individuals who are older in age, on average in their mid to late 70s, 97% male, which reflects the veteran population. 21.7% were non-white, and I'll sort of touch on this in terms of our future directions with some of this research. On average, these individuals had around 5 comorbidities, 7.1% had serious mental illness, and in the year preceding their hospitalization for this CHF exacerbation, they had on average 3 ER admissions. And this last point, this is the average healthcare cost expenditure for these patients in the year preceding their admission. Nearly $40,000, and this is compared to the national average of $5,000 to $6,000 per person. So this really, again, is highlighting the sort of exorbitant healthcare cost and burden on the healthcare system associated with CHF. So looking at our outcomes, and this is for the overall sample after 30 days following 30 days of their admission to the SNF, 7.1% had died. After 1 year, this number jumps to 43%. And for hospital readmission, just over 10% were readmitted after 30 days, and nearly 40% within the year after the admission. And now looking at some of the outcomes a little bit more closely, and I'm going to try to move myself out of the way here. My window doesn't look like it can, but that value is 6 up here. And so what we did, what you're seeing here on the x-axis is the cognitive function scale rating. So we divided this group up into 4 subgroups. One was intact, and the others were mild, moderate, and severe in terms of their level of cognitive impairment based on their cognitive function scale rating. And then what you'll see here on the left is the hazard ratio, with this intact group serving as the reference point. And what you can see here is a stepwise increase in risk associated with level of cognitive impairment, such that there's 6-fold increased risk for death 30 days after admission to the SNF in this most severe group. And still you're seeing 1.7 and 2.3 fold increased risk in this mild and moderate group. And this is the cognitive function scale rating controlling for delirium, controlling for the other comorbidities that we had taken account of. And now looking at delirium independently, and again, controlling for cognitive impairment, controlling for some of these other comorbidities, you'll see here we have just 2 groups. Those who are identified as not having delirium on the confusion assessment method, the CAM, and those who were. And you'll see that these they have a slightly increased risk in this delirium group of death after 30 days. And I just comment, these differences are significant. This difference is significant on the preceding slide as well. These differences are all significant differences. This one probably owed to a fairly large sample size of over 24,000. Now, what we also wanted to know was whether there was additive risk for mortality when delirium was superimposed on dementia. So some of these patients were likely to have pre-existing dementia, but in the context of their hospitalization, many developed delirium. And so we divided these further into one group that was intact or on that mild side of cognitive impairment, and another who were on this moderate to severe side. And you'll see in blue, these were the members of the group without delirium, and in orange here, these represent folks who had delirium. And you can see that even within these groups, that delirium was associated with an even more increased risk of mortality. So 1.6-fold versus this group without delirium, and here increased beyond that, just associated with moderate to severe cognitive impairment alone, suggesting that if you have cognitive impairment or dementia and delirium, that you're going to be worse off in terms of outcomes. And this is somewhat intuitive, but it's I think something that is important to recognize, given that many of these patients with congestive heart failure have some level of cognitive impairment or even dementia at baseline, preceding before they're hospitalized for these acute exacerbations. And so just briefly some conclusions. We found again that both cognitive impairment and delirium, they independently and significantly increase mortality risk. Mortality risk increases according to the severity of cognitive impairment, such that those with the greatest level of cognitive impairment have the highest mortality risk. And mortality risk was highest when cognitive impairment and delirium co-occur. And so again, I apologize for my face here blocking my slides, but I'm a neuropsychologist, and so I'm always looking to better understand what my role could be uh, in the various fields that I'm working in, and this includes cardiology and in this case, more specifically, congestive heart failure. And so I think what this represents for me and for my colleagues in other brain health fields is an opportunity to collaborate with cardiologists. And I think I find myself typically collaborating with other brain health specialists or psychologists, whether it be neurologists or other psychologists, social workers, et cetera, much less frequently with cardiologists. And I think that given what we know about the connection between the heart and the brain, I think this could be our foot in the door for just more interdisciplinary care, collaborative relationships. I think that this represents these hospitalizations for exacerbation represents an opportunity to identify cognitive impairment and delirium in a very critical period for these patients. If we're able to determine when they are hospitalized that, okay, hey, this person has dementia and they've developed delirium during this hospitalization, they're likely to have a very poor outcome or at much greater risk for that. And that might mean that we're able to tailor their care differently or their transition to the SNF differently to better support their needs moving forward. And that we might not be dealing with the same patient, that each patient has individual needs. And I think, and here's the bread and butter. Our bread and butter as neuropsychologists is communication and education, and both for among providers and patients and their families. And that while cardiologists might have more limitations on time, and they're for very good reasons, and they're managing medications and other critical factors, we as psychologists have a little bit more time to really take a deep dive into who these patients are, where they're coming from, what type of support network they have, and it allows us to intervene, at a critical period. Whether that whether that involves sort of motivational interviewing techniques, or sort of some cognitive rehabilitation and things like that. This really is a critical window where I think our services could be used in a sort of more medical setting. And again, speaking to designing strategies, whether it's through motivational interviewing or sort of discussing with family members as to what approaches might be most helpful for this individual to maximize adherence to this CHF regimen, which is very complicated with medications and so forth. It may be that this person is living alone and their level of cognitive impairment, they really cannot handle the complexity of their medication needs. And it might be in our best interest to really discuss with caregivers or family members or anyone who can be supportive out in the real world, to sort of make a plan moving forward to best support patient health. And finally, I'm always interested in determining the incremental value of a neuropsychological assessment or a cognitive assessment or a cognitive screening. What I've just talked about is predictive value. So we're able to look at these statistics at their admission to the SNF and track them, and then predict who might be worse off in 30 days, 365 days. But what I'm really concerned about is the actual impact. So can we, if we were to intervene at this critical stage with some of the strategies that I sort of threw out there, are we able to reduce cost savings? Are we able to mitigate some of these long-term outcomes like increased mortality and rehospitalization? and that's the key. But I think, you know, I've sort of gone over the big picture here of what's at play, and we've got more work in the pipeline, looking at different factors that are impacting these outcomes, including things like depression and suicidal ideation and things like that. And so, and again, I'll just come back to this idea of precision medicine, that not all patients are created equal. We know that, but I think that in identifying cognitive impairment and delirium in these patients with very simple screening measures, you know, it doesn't have to be a full neuropsychological test battery of 2 hours. This can be something that is done sort of bedside. We may be able to really identify patients who are at more critical levels of risk for poor outcomes. So thank you for listening, for watching. I'd like to acknowledge the rest of my team, including Jim Rudolph, who's the director of the Center for Long-Term Services and Supports at the VA, Steve Correa, who's another neuropsychologist like myself, and the director of the clinical research in the memory aging program at Butler Hospital here in Providence, Lan Jiang, our data analyst, and Caroline Magical, who is a fellow in nursing here in our team. And I'd like to thank all the veterans and the VA for providing this data and allowing me to speak more on veteran needs that you know, hopefully my hope is that this data can generalize to the CHF population at large, and not just the veteran population. I'll just speak for a second. You know, I know this is after the acknowledgments, but I think that I spoke about this, our demographics. I want to come back here to, I'm sorry for going all the way back, but we talked about 21.7% of the patients being non-white. And this is nationally representative of the veteran population, clearly mostly males. But I think we're lucky to have such a large proportion of non-white patients. And I think much has been raised over the last year of systematic inequities among minorities in healthcare and provision of healthcare and services, and poor health outcomes, of course, most importantly during the COVID pandemic. But I think that looking more closely, having a large data set like this, and having a percentage of patients who are non-white will allow us to speak more to these issues at play that are clearly not just impacting this veteran population, but our population and at large in the United States and in the world. And this is something I'd like to focus more on moving forward with this research, and I'll leave it at that as my last note. But thank you again for listening and watching. It was a pleasure.